Hello, and welcome to another episode of the Dutch webinar series. This webinar is presented by Dr. Tori Hudson, and we're very excited for her to share her expertise in regard to debunking common myths and misconceptions surrounding menopause, perimenopause, and MHT, which stands for Menopausal Hormone Therapy. Dr. Tori Hudson, a naturopathic physician, graduated from the National University of Natural Medicine in 1984 and has served the college in several capacities, including medical director, associate academic dean, and academic dean. She is currently a clinical adjunct professor at NUNM, Southwest College of Naturopathic Medicine, Bastyr University, and the Canadian College of Naturopathic Medicine. Dr. Hudson has been in practice for more than 40 years and is the medical director of her clinic, A Woman's Time, in Portland, Oregon. She's also the co-owner and director of product research and education for Vitanica, which I'm sure a lot of you know about that supplement company. It's wonderful. And the program director for the Institute of Women's Health and Integrative Medicine, which they have really great conferences. She is also the founder and co-director of NERC, a nonprofit organization for accredited naturopathic residencies. In 2021, she received the 2020 American Botanical Council prestigious Freddie Cronenberg Excellence in Research and Education in Botanicals and Women's Health Award for 2020. She's a nationally recognized author. She wrote Women's Encyclopedia of Natural Medicine, which I actually have right here on my desk. And she's a speaker, educator, researcher, and clinician. Dr. Hudson serves on several editorial boards, advisory panels, and as a consultant to the natural products industry. She also writes monthly columns and freelance articles for several publications. Dr. Tori Hudson, it's great to have you with us today. I'll hand the floor over to you.
Hi, everybody. Welcome. Glad to be with you and glad to be in collaboration with Dutch. And they have asked me to share some content about myths and misconceptions of prescribing menopausal hormones to perimenopausal and menopausal women, which I'm thrilled to do because this is menopause is having a moment out there, in case you haven't noticed. And it's taken a long time to get here. But we want to make sure we're doing things not just effectively, but safely. And so we're going to spend some time talking about that. I do have some disclosures. I'm not only on the Speakers Bureau for Precision Analytical, but a few other Speakers Bureaus there. You see there, I'm co-owner and director of research and education for Vitanica and on the scientific advisory boards of several companies. So when I was thinking about this presentation, this little mini flood of medical myths came to my mind from my childhood. Some of them, the first one definitely from my childhood. I always remember my mother saying, "You can't go in swimming until you haven't been eating for an hour, and so that you don't cramp and you don't die," right? So this turns out is not true. This myth is false, and you can consume a normal size meal right before swimming and it will not cause cramping. Now, there might be some caution if someone is overeating. They tend to feel a little more tired and, groggy. So maybe avoid swimming right after a super heavy meal. But other than that, this statement is a myth. And then there's this one. I remember this from my teenage years as well. She told me that I shouldn't be so eager to start shaving my legs because the hair that grows back is going to grow thicker and darker. Well, that also is false. But because the hair is newer, it may not have been bleached out yet by the sun. And so it does appear thicker and darker, but it is not really thicker and darker. And then there's this one. I still I think, have this one in my head and am mindful of it when I'm out camping and swimming and such. So the myth is, if you go outside with wet hair on a cold day, you'll catch a cold. False. We know colds are caused by viruses. You can't get a virus just from being outside in the cold. We may feel sick if we're outside all day in the cold or rain, runny nose, chills, fatigue, but it's not because we have a virus. But those symptoms are the same or similar symptoms to having a cold. And I think that's why that myth got some traction. Okay, what about cracking your knuckles causes arthritis? Not true. 30-year studies showed this is not the case. But if we do crack our knuckles, it can lessen our grip strength over time because of just repeated stretching of those tendons. So that's another fun one. Here's one that lingers on today, and patient after patient says, I drink 8 glasses a day. So that's the long-standing, generation standing, I would say, that we need to drink 8 glasses of water every day in order to stay hydrated. Well, it turns out that is also a myth and is not true. Obviously being dehydrated isn't great, but the idea that we need to drink 8 glasses has no real scientific backing. So I do not advise people to drink 8 glasses of water a day. In fact, many women with, especially postmenopausal women with nocturia, you can improve their nocturia by decreasing their water intake to something a bit more reasonable. But then let's move on now that we've covered our childhood and at least, let's talk about these menopausal hormone therapy myths. And MHT does stand for menopause hormone therapy. That's a fairly, more recent term and terminology that's being used rather than ERT or HRT. So these are, to me, is the top myths that I run into, you might say, with patients and with colleagues and with students and such. So these are the ones that I wanted to target today, is that estrogen therapy causes breast cancer, that estrogen and progestogens significantly increase the risk of breast cancer, that screening mammograms must be done prior to prescribing menopausal hormone therapy, that women should stop taking menopausal hormones at the age of 60 or by the age of 60. Another myth, postmenopausal women can safely initiate or start taking systemic menopausal hormone therapy at any age. And then last but not least, progesterone cream is an adequate delivery method to provide endometrial protection in women who are taking systemic estrogen. All those are myths. And now we get to the details. I wanted to have these next 2 slides really show you I would consider essential studies that have been done on this issue. Not all within, some precede the last 20 years, but a majority of it is the last 20 years. So these are landmark studies on menopausal hormone therapy, important, essential studies to be familiar with. So you could just look up any of these. VET stands for venous embolism, or strokes or clots, and that should be VTE, by the way. Didn't catch that one typo. That was why I was stumbling there. But the PEPI trial, the KEEP study, the Million Women study, all the many, now dozens of spin-offs from the WHI study, all these are, you could look them up and get cliff notes. And if you don't want to read each and every study in detail, you can often read the introduction, the results, the discussion, and you're in good shape. A second whole slide on key landmark studies on this topic. The Rejoice study, Replenish, all these are in the last few years. I'm going to talk about a few of these in relationship to our myths. So hopefully giving you the code names of these studies will help you enhance your education even more so. And then I highly recommend some of these position statements and consensus guidelines. Ultimately, if you could read all of them, great. But we have some now that are moving forward into more recent years rather than back to 2015. But for example, the latest position statement on menopausal hormone therapy from the North American Menopause Society was published in 2022. And that is a excellent document, a review of the literature with citations and in a sort of a cliff note version, but breaking it down, hormone therapy and breast cancer risk, hormone therapy, endometrial cancer risk, hormone therapy and cardiovascular risk, hormone therapy and osteoporosis. I shouldn't just say risk, benefits and risks. And it really dials it in. There's also the most recent publication was their position statement on non-hormonal therapy for perimenopausal and menopausal women. This is, talking about SSRIs, gabapentin, etc., and some of the newest drugs that are like the Veoza and botanicals and nutrients. And that's certainly not the document you want to rely on for your education on botanicals, nutraceuticals, and nutrition as it relates to menopause symptoms. But they certainly do highlight the what they consider the highest quality studies that have been done. But it's limiting. If you just went by that, it would be very limiting in terms of botanicals. But they also have an excellent position statement that's not too old on genital urinary syndrome of menopause and osteoporosis. So I highly recommend these position statements. And then the consensus guidelines on testosterone is also extremely good. So before we get to the menopause hormone myths, I just thought it would be good to start with some of the symptom issue myths. And the myth is really that you have to have vasomotor symptoms to be diagnosed as perimenopausal. Vasomotor symptoms are hot flashes and or night sweats. So that is a myth. That is not the determining diagnostic criteria for perimenopause. The diagnostic criteria is this. It is an ill-defined period of time, individual for each woman, that surrounds the final years of a woman's reproductive life. It begins with the first onset of the menstrual irregularity, which could be very subtle, by the way, and we'll talk a bit more about that. And then perimenopause ends after 1 year of 12 consecutive months of no period. At the age appropriate time. Obviously, if you have 12 consecutive months at age 25, there might be, in other words, there are other causes of secondary amenorrhea. There are 2 stages to the perimenopause or menopause transition. There's the early transition phase where the cycles are mostly regular with a few interruptions. And that's the subtle part I was talking about. And then the late transition part of perimenopause where amenorrhea becomes more prolonged and lasts for at least 60 days. That's the late perimenopause transition up to the final menstrual period. And then, like I said, 12 consecutive months without a period and an FSH of greater than 25. This is something called the straw data. And this is just, I wanted to show this slide just to highlight. You can see this -2. This is the early menopause transition or perimenopause I was talking about. And then here's the late phase of perimenopause. The hormone markers are not reliable in perimenopause. What I mean by that, they're reliable for that day, but they're not they are very changeable, very much in flux, and it's very difficult to conclude useful prescribing information from those kind of test results that are so variable. And then the late perimenopausal phase, might last 1 to 3 years. In total, that transition phase could be kind of 4 to 7 years-ish. Think about that, which may or may not include any other symptoms other than a change in the menstrual cycle. That's the defining criteria. Although in the late perimenopause, vasomotor symptoms are likely, but in the first 2 years of postmenopause, that's when vasomotor symptoms are most likely. But the average duration of vasomotor symptoms, according to a study that was done not too long ago, is 7 years. And not everybody's happy to hear that number. Okay, let's talk about some also just to make sure we're all on the same page, you might say, what are symptoms of perimenopause and menopause? There are classic ones. These are the classic symptoms, whether you're peri or postmenopausal. A change in the menstrual cycle is going to happen to everybody one way or another. And obviously it can happen by removing the uterus, but removing the uterus is not menopause. Removing the ovaries is surgical menopause. Um, um, or, obviously having a hormone IUD is going to alter the menstrual cycle pattern. Taking or hormonal birth control pills with estrogen and progestins is going to be clouding the picture of when is this woman in menopause. You have, with the hormone IUD and the birth control pills, you have to learn how to diagnose menopause. So when she no longer needs contraception, if that's why she's using those. For example, a Mirena IUD, you can check an FSH level at any time and get the number that you're looking for. And you want above 30 2 months in a row, 1 month apart, to determine, okay, yeah, that hormone IUD is no longer needed. If she's on birth control pills, you have her, and if she, and you need to have her be off the pill for 6 or 7 days, and on the 6th or 7th day, you take her FSH, and it again has to be above 30 2 months in a row. And we're trying to cover our bases here. That's why we don't use above 25. We're trying to cover our bases so we don't risk someone getting pregnant if they're having a sex life that could lead to that. So, classic symptoms: change in the menstrual cycle, vasomotor symptoms, vulvovaginal symptoms that can include itching, dryness, burning, dyspareunia, sleep disturbances, so common in all sizes and shapes. And psychological symptoms are more come in perimenopause. You get either a recurrence of depression, anxiety is more likely, or a new onset or a worsening. Any of those three things can happen in perimenopause, a little bit more likely than before, or then in postmenopause. There's no one universal symptom or syndrome. It's very, very individual. It's a really beautiful example of treat the individual, know the individual. There are, those classic symptoms are really in the US, because there are things that look a little bit differently elsewhere, which is interesting. If you look around the world, in South Africa, for example, women are pretty unhappy with their mood disorders, their sexual dysfunction, and their joint and muscle pains. But in vasomotor symptoms and joint and muscle pains are particularly highly reported. In Australia, vasomotor symptoms and genital urinary dysfunction is the most common. In the US, it's vasomotor symptoms and body aches and pains. Remember that little tidbit. In Asia, more depressive disorders. Europe, sleep and depressive disorders. So good to know about what happens in women who are living in other places, or perhaps coming from other places. But we don't just have our classic symptoms. We have a laundry list of things that can occur. They're not necessarily occurring in a problematic way. I mean, every woman is going to have skin changes, dental changes, likely changes in body weight, but not every woman is going to have aching joints or palpitations or brain fog or fatigue or sexual dysfunction. But there are changes that are just actually occurring because of that decline in estrogen in particular. And I don't even have it on here, I don't think, but the voice can get a little deeper, a little more hoarse because of decline in estrogen. So there's all these other changes to be aware of and symptoms to be aware of that need, perhaps, if depending on the degree of bothersomeness it is for her, our treatment strategies need to include addressing those symptoms as well. Okay, now let's get to the main event, which is what are the main myths about menopausal hormone therapy. And we got to start with breast cancer. And the two myths that I'd like to address is that, number one, estrogen causes breast cancer. And number two, estrogens and progestins significantly increase the risk of breast cancer. So those are both myths, and I'll make my case with a few key studies and scientific evidence. Let's start with 1 in 8 breast cancer affects about 1 in 8 women in the United States. So it's important to have an accurate understanding of the potential effect of menopausal hormone therapy on breast cancer risk. And we need to understand the differences between estrogen alone, estrogen and a progestogen, the difference between an estrogen plus bioidentical progesterone versus estrogen plus a progestin, which is synthetic, because they have a little bit different effect on breast tissues. And I'm going to highlight some research on that. The different types of formulations, timing of initiation is more related to other issues, not so much breast cancer, but duration is definitely related to the slight breast cancer risk. And then all kinds of select patient characteristics play a role in breast cancer risk, and they play the most dominant role, and we'll come back to that as well. Okay, in the original WHI, Women's Health Initiative study, published in 2002, continuous combined Premarin and Provera, that's what those two CEE and MPA mean, resulted in an increased risk of breast cancer, but it was a rare absolute risk. And so let's go into that a little bit. What that really meant was 9 additional breast cancer cases per 10,000 women per year. And the increase in breast cancer risk was found after 5.6 years when they stopped the study, but it started to occur kind of in the late part of year 3. So by year 4, there was this ever so slight increase, but this was considered nominal in statistical terms, and it was actually non-significant when adjustments were made for multiple risk factors. But this was what all the hullabaloo was about. And even because they had a cutoff, I believe it was 1.28 in their setup of the study and their safety analysis. And once it exceeded 1.28, they stopped the study, and it got to 1.29, but is not actually considered statistically significant in the big picture of all their risk factors. The risk, like I said, appears to start somewhere late in year 3 of using Premarin and Provera, and it remained elevated at 20 years post-intervention. In the post-publication analysis, that increased incidence of breast cancer, this is a key point, was limited to women who had prior exposure to menopausal hormone therapy, whereas women without prior exposure, these are menopausal hormone therapy naive women, breast cancer incidence was not significantly affected by Premarin and Provera in this same time frame for a total of 20 years. The attributable risk of breast cancer since the study. The attributable risk of breast cancer in the WHI is not only not quite 9 additional per 10,000, but the number I like to use in my speaking and with my patients is that number is less than 1 additional case of breast cancer per 1,000 users annually. So if they're on menopausal hormone therapy for 4 years or longer, let's say estrogen and progestogen of any kind for the moment, the worst we could say is not quite 1 more case per 1,000 women annually. And this risk is slightly greater, get this, than that observed with 1 daily glass of wine, but it's less than 2 daily glasses of wine, and similar to the risk reported with obesity and low exercise. So put it in perspective, and it's sort of like pow, and not quite 1 out of 1,000, even more pow. So this is the original data of the 2002 E plus P, the Premarin plus Provera, and you see that 3.8 and the placebo 3.0. This is the number I'm talking about. That calculates as to not quite 1 woman out of 1,000. A slight increased risk of clot, strokes, heart disease. Those were all in the increase, and the worst was clots. So DVTs. And remember, the prescription that was given was oral estrogen and oral progestin. There was actually reduced and there was reduced hip fractures and colon cancers in this group. So we now have some benefits to cogitate on. Now, what about the estrogen only? So when they stopped the original WHI at 5.6 years, they continued the estrogen only arm in women who did not have a uterus, because that's typically the prescription. If they need estrogen and they don't have a uterus, they don't need to take the progestogen. So now you see, let's just track down to breast cancer, because that's what we're talking about. The less than 1.0 hazard ratio. This means that the women on estrogen only had a lower risk of breast cancer than women who did not take estrogen only. Again, maybe a pow to you. Again, benefits to bone, not quite a benefit on colorectal cancer, but really not an increased risk, and really no increased mortality overall. So these are data points, estrogen only, and the previous slide, estrogen and the progestin in the original WHI. So now let's look at, make our case a little bit more detailed about estrogen only. So in the WHI observational study, this study directly compared different estrogen doses, formulations, and route of delivery of the estrogen among women with a estrogen only, and women who had a hysterectomy in relation to invasive breast cancer incidence. This was a large multi-center prospective cohort. They had 40 different sites around the United States, and the results after 8.2 years follow-up indicate that invasive breast cancer risk did not differ in women with a hysterectomy using estrogen alone when directly comparing different estrogen doses, formulations, or deliveries. So whether it was a patch or oral, it was the same. Lower than average doses. So average dose of Premarin is 0.625, which is the same as an average dose of oral bioidentical estradiol, 1.0 milligrams, which is the same as bioidentical estradiol patches, average dose 0.05 milligram patch. So less than those average doses was associated with a similar risk when compared to the conventional dose. So lower or the same dose didn't seem to really matter. Transdermal estradiol may confer a slightly less risk of breast cancer than oral, but the sample size was too small and not powered, so we can't really assert anything about that. We can assert things about transdermal estradiol for less stroke, less DVT, less ding on triglycerides, less ding on liver enzymes, etc. But in terms of breast cancer risk, not really. Like I said, so the oral, maybe there was a trend towards a little higher than the transdermal, but the sample size was too small, so I wouldn't really take stock of that. I would not assert that. Okay, in JAMA 2020, we have now 20 years and even a little more than 20 years of data analysis and medium. And this, again, was analysis of the estrogen-only arm of the Women's Health Initiative. Estrogen alone, they concluded, after 20 years of follow-up, reduced incidence of and mortality from invasive breast cancer, while combining the estrogen and the progestin elevated the incidence slightly, right? Less than one more woman out of 1,000, but did not increase mortality from breast cancer. So estrogen alone, no increase after 20 years of follow-up. Estrogen and progestin confirmed that slight increase, but not increase in mortality. Love that. And then, but to be fair, I wanted to just say, yes, there are some other data points. The first bullet point there is a repeat of what we'd already said from JAMA 2020. There are smaller, and that was a randomized controlled trial, the WHI. There are some smaller randomized controlled trials, again, showing estrogen only, reduced risk. The Nurses' Health Study, which is observational, estrogen only, times 5 to 9 years, of use, no increased risk. Longer, like 15 years or more, observational data, there is a slight trend. towards increase even with estrogen only. In the collaborative group, which was fairly recent in the last 5 years, 5 to 9 years of estrogen only, again, very, very slight increased risk. And the Million Women study is kind of an outlier, and it's a survey study only, but there was that increased breast cancer mortality in that reported study. So, but our best data, the randomized clinical trials, reduced risk with estrogen only. That doesn't mean we should go out of our way to give women estrogen to reduce their risk. It's the matter of if we're having our compelling reasons and our analysis and criteria for prescribing estrogen only, we can be pretty comfortable in assuring her, hey, this doesn't really seem to increase your risk of breast cancer at all. Again, this is a repeat. Just wanted to emphasize this study, the JAMA study of 2020. After 20 years, estrogen only, lower risk and lower breast cancer mortality. And the rest is a repeat. Okay, so the WHI summary to date as it relates to breast cancer. Premarin alone significantly reduces breast cancer risk and cancer mortality. So this is the WHI data. The Premarin and the Provera, when initiated in menopausal hormone therapy naive women, it does not increase breast cancer risk and it does not increase breast cancer mortality, even in women with a family history of breast cancer. And we'll swing back to that. So even if an estimated increased risk of breast cancer is accepted, that slight increased risk with estrogen and progestin at 4 years or more, not quite one more woman out of 1,000, that is a very, 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 very low risk. I'm not, trying to dismiss one woman, but that it really puts it in perspective, I hope. The worst you could say, again, is this not really statistically significant, very, very slight increase risk, not even one more woman out of 1,000. I know I'm being repetitive, but I'm trying to make some points. And again, put things in perspective. I love that stuff about the alcohol, obesity, and inactivity. So I think all this is repeat, except to say vaginal estrogens. If you're prescribing vaginal estrogen for the purpose of GSM, dryness, burning, itching, leakage, overactive bladder, stress incontinence, urinary incontinence, dyspareunia, those are tiny doses. The general maintenance dose is twice a week, unless you're using the low dose ring that stays in for 3 months. There is no increase. This has nothing to do with breast cancer, nothing to do with heart disease, no benefit to bones, no benefit or harm to heart, no benefit or harm in terms of stroke or DVT. It's a local phenomenon. It's like chapstick. So let's look towards the bottom here. There is no additive effect with menopausal hormone therapy with age or elevated personal breast cancer risk factors. So if she has a breast cancer risk, leaving genetic testing aside for a moment, let's say just a family history of breast cancer or obesity, she has her risk of breast cancer. And we're not adding to that by her going on menopausal hormone therapy. And a lot of women just relax with that reassurance. She's talking to me, we're talking about her family history. Oh yeah, her mother had breast cancer or her sister had breast cancer. And we don't know anything about BRCA testing. There is no reason for her to not take menopausal hormone therapy if she has the indications to do so. We are not adding to her risk. Very important concept. So let's talk though about the genetic testing a bit. Menopausal hormone therapy does not further increase the relative risk of breast cancer in women with a family history, like I just said, but also it does not increase the risk if she's had her ovaries removed, bilateral sempingio-oophorectomy, because of a BRCA1 or 2 mutation. If has BRCA1 and or 2, if she has her ovaries removed, menopausal hormone therapy is not contraindicated for her. But you notice I said ovaries removed. What about if the genetic risk and she's less than 50, no increased risk of young onset breast cancer breast cancer with the use of an estrogen and a progestogen. And estrogen alone actually reduced diagnosis of young onset breast cancer in people with a genetic risk. So hopefully those highlight and clarify some things for you as well. Let's look at the role of progestogens and make some distinctions. Some, but not all, observational data suggest that bioidentical progesterone or oral micronized progesterone may have less effect on breast cancer risk versus that slight increase with the progestin. We do need randomized controlled trials to confirm this, and I am going to come back to some important data on some French studies and a recent one from the United Kingdom on this distinction between bioidentical progesterone and progestin on the breast. But again, even a progestin with an estrogen only ever so slightly at 4 years and more, not quite one more woman out of 1,000. And estrogen alone, not at all. Why not try to take away the 1 out of 1,000? And we might be able to do that with progesterone with our estrogen versus a progestin. And again, I'll come back to that at the end. Clinical data from observation studies such as the collaborative group study report no difference in effects of Premarin versus estradiol on occult breast cancer growth. It's the same. There's no real difference. Both oral and transdermal estrogens appear to have similar effects on the number of breast cancer diagnosed. Remember, we did say earlier the transdermal estradiol. Look, there was a perhaps trend in the favorable department, but it was too small in numbers. It wasn't statistically powered adequately. And again, low dose vaginal estrogens, no effect on breast cancer risk. And it's considered safe in breast cancer patients. Again, we'll come back to that a little bit. So sometimes there is this myth that you need to do a screening mammogram before you start menopausal hormone therapy. There is no guideline or standard of care that says so. So that is a myth. However, might you make a judgment call and feel more comfortable doing that? You might. More importantly, she might. So I'm not arguing that it perhaps is prudent, but it's not required. It's not standard of care. Perhaps you would want to in the previous 1 to 2 years before initiating. We'll talk a little bit about different recommendations for screening. And then there's also been a myth about, if you should maybe stop hormone therapy for 2 months before the screening mammogram, but because hormone therapy can increase, breast density, but brief hormone therapy suspension in this Reed study was associated with small changes in breast density, but did not affect recall rates, and there was no evidence to support this myth. So I just kind of threw up this slide. You might want to print this one out if you don't have it already. I like to refer to it with patients sometimes just to share with them there are different guidelines for average risk women. And that's a different guideline for women who are above average risk. But average risk, ACOG, now you see their guidelines. The U.S. Preventive Services Task Force just updated they kind of were the ones that threw a wrench in the system a few years ago. But now they're back to every 2 years, beginning at age 40. World Health Organizations every 2 years, starting at age 40. American Cancer Society is even a little bit different, depending on those 3 different age groups there. Again, these are all guidelines for average risk women. And it is confusing for our patients. It is confusing for us as well to keep up to date on this. But the latest is sort of most of the consistency is around starting at 40 and average risk women every 2 years. Okay, let's go to our next myth and about duration. Women who take menopausal hormones should stop by the age of 60. This is a myth. There is no guideline or standard of care about that. But I can't tell you how often women are told that and deprived of hormones. The age of 60 has something to do with initiation, and we'll come back to that. So this is a brand new, there's lots of things to read on this topic, but this is really quite new. When did this is like 2024, right around April, early April, this came out. And it was made a big impression on me because it really kind of punctuated the important points. So the objective of this study was, can menopausal hormone therapy be continued after age 65? That was what this one was about, not 60, but after age 65. And here's what they found out. Estrogen monotherapy beyond age 65. Now, these were women who were already on it. We're not talking about initiation. We're talking about women who were on it and should they stop or not at age 65 and beyond. Estrogen monotherapy beyond age 65 was associated with significant risk reductions in mortality, breast cancer again, lung cancer, colorectal cancer, even CHF, and even VTEs, AFib, acute MIs, and dementia. Next bullet point, estrogen and a progestogen combo therapy, whether it was estrogen and a progestin synthetic or estrogen and bioidentical progesterone. Yes, there was this increased risk of breast cancer by these same small numbers, even tinier than before, but such risk can be mitigated using lower dose transdermal. That's a new finding, or a vaginal estrogen and a progestin. So a vaginal estrogen for systemic purposes would be like the fem ring. The E string or S string is low dose for just GSM, but the fem ring comes in two different doses, is a way to deliver it systemically, but just through the vagina. And then estrogen plus progestins exhibited significant risk reduction in endometrial cancer. Absolutely. You have lower risk of endometrial cancer by staying on menopause, the right doses of menopausal hormone E plus P versus none at all. Reduced risk reductions in ovarian cancer, ischemic heart disease, CHF, and VTE again. Now, here's was surprising to me, but estrogen plus the bioidentical progesterone, and when you use 100 milligrams a day of bioidentical progesterone with average doses of systemic estrogen or less than average, that is considered safe for endometrial protection. There's only 2 doses of bioidentical progesterone that are proven safe. It's either 100 every day or 200 12 days out of the month. And by the way, if I go above average doses, I do bump that up to 200 every day, not just 100 every day. But bioidentical progesterone in this study, plus the estrogen, the only risk reduction was in CHF. It wasn't in endometrial cancer. It doesn't mean it caused it, but it wasn't associated with reduced risk compared to placebo. Conclusions: among senior Medicare women, menopausal hormone therapy continued use beyond age 65 varies by type, dose, type, routes, and strengths. Risk reductions appear to be greater with risk reduction is better with lower rather than medium or higher doses. And then again, the vaginal or transdermal rather than oral. And a little bit, this one called out a little bit better with the estradiol than the Premarin when it comes to breast. That is not confirmed in randomized controlled trials. Okay, next myth. Any delivery route of estrogen is safe at any age. Not true. Any delivery route is safe at any age. No. After the age of 65, you need to switch. If she is on oral estrogen, you need to switch to transdermal estrogen. Doesn't have anything to do with the progestogen oral transdermal, but oral increases clotting factors, and with age, we don't metabolize hormones as well. There's the pharmacokinetics are different. Our risk because of plaque and uh, uh, stiffness, our risk for DVTs and strokes goes up. So you got to switch to transdermal estrogen. And then we're always, whenever we have a woman on menopausal hormone therapy at any age, minimally annually, we're going to weigh what are the benefits and what are the risks for her. But this is especially important as she gets older. Why are we doing this? Is it quality of life issue? Is it reducing the risk of an illness for which you're at increased risk for, and estrogen does that in certain doses, like osteoporosis? Or are we treating something like osteoporosis? That's the sort of the third bucket. By the way, average or less, I'm sorry, less than average doses of systemic estrogen can slow bone loss, but only average doses and above reduce fracture rate. So keep that in mind. So if she has no contraindications, and contraindications evolve and change over time, so that's part of the annual update. But why are we giving it to her? If it's a quality of life issue, the only way we know if she still needs it is if she has gone off and on her own and said, "Oh, I went off for 2 weeks because I forgot it on my vacation and my hot flashes came back miserably." She's not going to be wanting to go off. But the only way you know if she still needs menopausal hormone therapy to resolve a quality of life issue is if you stop. There's no test to predict that or to know that or to understand that. It's an experiment, and she has to decide, does she want to take that experiment or not? And if there's a contraindication, then we have to really say, yeah, we do need that experiment because you had a DVT last 6 months ago, and now we need to revisit this whole thing. Or your triglycerides are way up, or now you have type 2 diabetes. Any number of things change. So what's the quality of life issue? What's the disease prevention issue? And there's a lot of nuances here, if she has ovaries or not, and at what age she was menopausal or not. A lot of things here determine risk for cardiovascular disease, osteoporosis, and Alzheimer's dementia. So that bucket is important to really become familiar with what are the risk factors for those three areas. And then, as I said, what disease condition, pathological change can systemic estrogen actually treat? Possibly osteoarthritis, definitely osteoporosis in certain doses. Okay, myth. Postmenopause, this is about initiation. Postmenopausal women, no matter their age, could start systemic menopausal hormone therapy. By the way, and I'll probably say it again, she can start vulvovaginal estrogen for the purpose of GSM or atrophic changes at any age. This myth does not have to do with that. This has to do with systemic. You cannot start menopausal hormone therapy safely at any age. That is a myth, and here's some data points. The therapeutic window for initiating menopausal hormone therapy occurs shortly after menopause, at which time the benefits of initiating hormones may outweigh the risks for many, many, many postmenopausal women. And that therapeutic window is a period of less than 10 years from her last menstrual period, or before the age of 60. Either one is the therapeutic window. And that is the ideal time to prevent urogenital atrophy, dementia, possibly cardiovascular disease, although that's not an FDA approved or standard of care guideline for prescribing. But for the prevention and treatment of bone loss, the window is better in the first 3 to 6 years after the last menstrual period. So women lose about 2% per year in the first 4 to 5 years. And if she had a family history of osteoporosis, especially a hip fracture. And if she has the quality of life bucket is super bothersome symptoms, um, systemic estrogen could be a good strategy for her. But we want to ideally start in the first 3 to 6 years. But the numbers you should really especially keep in mind, is the rule of thumb is don't initiate systemic menopausal hormone therapy if she's past 10 years after her last menstrual period or after age 60, because doing so increases the risk of DVT, stroke, cardiovascular disease, and Alzheimer's dementia. Nothing to do with low dose vaginal, but systemic. Now, might there be a scenario where you have not solved her quality of life bucket by other means, and she has severe vasomotor symptoms, especially at night? They're keeping her up. She's now fatigued. She's depressed. She can't think straight. Other things have been tried and is not working, and maybe you would initiate systemic menopausal hormone therapy for her severe vasomotor symptoms, because all the herbs, the non-hormonal therapies, nothing has worked, and she's done trying. I mean, because there's probably always something else to try, but she's done trying. But that's the exception. It's not all in this menopause moment that we're having in 2024, and you're getting this influx of inquiries and women reading something, and they're coming in and they're 63 and they want to start menopausal hormone therapy because they read this, and that. Well, our job is going to basically evaluate, assess, but likely discourage, and tell her, actually, for you, there's potential for harm that outweighs the potential for benefit. And there are exceptions. Okay. I think the last main myth is that progesterone cream is an adequate delivery method to provide endometrial protection in women taking systemic estrogen. This is a myth. And I know some of you might be getting squirmy in your seats, but let me make the case. There are very specific doses, forms, and deliveries of progestogens that are accepted methods of providing adequate endometrial protection based on adequate studies. Now, I have only found 5 studies to date that have been identified investigating the impact of bioidentical progesterone on the uterine lining delivered as transdermally, like a cream or a gel. 5. All but one study were randomized controlled trials, some of which had a placebo or a progestin as a comparator. So hopefully you can see the problem already if you're looking ahead at the slides. The studies were too small, too short to conclude safety. The estrogens were applied either orally or transdermally, and the dosing ranges were from high end of normal to moderate dosing categories of the estrogen. The transdermal progesterone creams were applied either sequentially or continuously. They range from 16 milligrams even up to 64. Some of you might be thinking, 40 milligrams a day. We'll come back to that. In one study, transvaginal ultrasound showed a significant increase in endometrial thickness. That means she's going to have a biopsy. All 5 studies had endometrial biopsies pre and post treatment. 2 studies indicated an adequate progesterone opposing effect by the same lead author, but it was only 28 days in duration. Who cares? 28 days. The dose of progesterone was at 15 milligrams BID or 40 BID in those 2 studies. That was one problem. Then there was a study that was 6 months in duration, and that was the 40 milligrams a day transdermal. And this study did have 19% of the women acquired a proliferative endometrium. Granted, there was no hyperplasia on biopsy, but the remaining 3 studies did not have an adequate progesterone cream opposing effect, meaning there was proliferative endometrium. There were 2 cases of complex hyperplasia. There was no cancer yet. One of the negative studies, the one with complex hyperplasia, was only 48 weeks duration. 2 of the negative studies were 12 weeks duration. So in general, I'll come back to these studies are too short, too few. There's concerning cases of endometrial thickening, of hyperplasia, and even complex hyperplasia, even in these short durations that were done. Keep in mind that endometrium stimulated by a systemic estrogen with inadequate progestogens in women with a uterus tend to get thicker and abnormal changes over time, more proliferative, more hyperplasia, more atypia, more cancers over time. These were only 12 weeks, 28 days, 6 months, and they were small numbers. So even when you read this study of, which is often the one that is cited as the rationale for using progesterone cream, 20 milligrams twice a day, with the systemic estrogen. These were 26 women were in each arm. Of the 52 post-treatment biopsies, 40 had the atrophic endometrium, 12 proliferative. There was no evidence of hyperplasia, but there was spotting. But the problem, again, too small, way too short. We need to study this issue on like 5 years, 10 years. So in this dose, the dose that's often referred to, it's still not providing safety data on using it with a systemic estrogen for endometrial protection. So don't do it, is my strong advice if you want to do no harm. So these are the doses of progestogens that are proven endometrial protection. So here we have oral micronized progesterone, either 200 milligrams, cycling it or with the estrogen every day, or you can do it 100 orally every day. Either of those two regimens is considered safe for average or less than average doses of systemic estrogen. If she doesn't tolerate this because of nuisance effects from the oral micronized progesterone, you could have a progesterone gel. There's a big pharma version. You could have it compounded. Don't rely on just a capsule in the vagina. That has not been proven. So you'd either do 45 milligrams more than 10 days a month, or 100 milligrams every other day is what that's a little confusing, but every other day. Though these are, and then you see others there that are proven doses. The synthetics, if it's continuous, you can stay in this range. If it's cyclic, you can go in that range. Okay, there are other myths. Women with a history of breast cancer cannot use vulvovaginal estrogen. That should say GSM. Sorry, we missed that typo. And progestins and progesterone have the same effect on the breast. So just kind of go through this a little more quickly. I'm going to have you look. This is the position statement 2020 from the North American Menopause Society and their guidelines for genitourinary syndrome of menopause. They encourage us to try lubricants with sexual activity and moisturizers 3 times a week. That's the sort of first line therapies. But moderate to severe GSM and non-responders to the lubricants and the moisturizers, there's many options. There's many low-dose big pharma vaginal estrogens. There's all kinds of compounded vaginal estrogen options, estriol, estradiol. There's vaginal DHEA, big pharma and compounded. There's this newer drug, ospemifene. You can get a genital effect by giving a systemic estrogen when she also has systemic symptoms. So that enough of that estrogen might find its way down to that tissue. You might need both for some people. If she has a history of breast or endometrial cancer, you might want to talk to her oncologist, but this is considered safe. But first line recommendations, they have a separate position statement for breast cancer patients. First line recommendations are, again, the moisturizers 3 times a week, and then lubricants as needed. But low dose vaginal estrogen is generally considered safe in breast cancer and endometrial cancer patients. It's better to use a ring or a tablet or suppository than a cream, because a cream gets a tiny bit of systemic bump in estrogen. If you're using just low dose vulvovaginal estrogen, then you don't, at these low doses and 2 times a week, you don't need a systemic progestogen if she has a uterus. Anytime someone has a postmenopausal spot or bleed, obviously that requires an evaluation. So here's there are 3 French studies observational studies that go to the point that bioidentical progesterone does not increase the risk of breast cancer and versus the progestin that only slight risk. So these are kind of you can ponder and look at, but there are bona fide 3 observational French studies that says the risk of breast cancer is slightly increased with the estrogen and the progestin, but not when it's the estrogen and progesterone. The second French study, estrogen, again, this is the if you look at the E plus progesterone, 1.0 is no increased risk. Now, this observational study did have that ever so slight increase, which is outside of our now 20 years of data from the WHI that estrogen alone does not increase the risk of breast cancer. But then this observational study, very, very slight. But see that progestins more so, at least, well, not that progestin, but the norethindrone, medroxyprogesterone acetate. This is a little higher than what we see in the WHI and most of the other data. But the point in the French study number 2, estrogen plus bioidentical progesterone did not increase the risk of breast cancer. This is a third French study also showing that estrogen plus progesterone, bioidentical progesterone, did not increase the risk of breast cancer, that third bullet point there. And then this is the brand new UK study in 2022. This was a population-based case control study, and 50 women aged 50 years or older, and it was a course of almost 20 years. Compared with women who never used menopausal hormone therapy, its use was associated with a very slight increased risk of breast cancer. Compared with never users, estrogen alone were not associated with breast cancer, whether it was bioidentical or Premarin. Progestogens appeared to be differently associated, meaning the bioidentical progesterone, lower risk, or at least not increased because it's not more than 1.0. And here we have that classic kind of 1.28, right around the same exact number as the WHI. So 3 French studies, observational, and 1 population-based control study recently out of the UK say bioidentical progesterone with an estrogen does not seem to increase the risk at all of breast cancer. And tracking back, even if it was a progestin, only not quite 1 more woman out of 1,000. So we have come to the end of our time together. And I think we succeeded in about a 60-minute presentation. Phew. And here's some resources if you want to access some things. And I thank Precision Analytical and their team, a fabulous team to work with. Really appreciate the collaboration and the trust. Thank you so much. And hopefully everybody now understand the main myths and how we can proceed smartly, wisely, safely, and effectively.
Thank you for joining us today. Watch your inboxes tomorrow for a link to the recording and to access the resources we shared today. You can learn more about the research behind the Dutch test at dutchtest.com/research. And make sure to visit the Become a Provider tab at dutchtest.com to register for an account so you can gain access to even more hormone education and research. And don't forget to follow us on Instagram at DutchTest for more hormone education, tips from our clinical experts, and more.